The history that I'd had, and a number of us have had, and I'm sure you'll have the same feelings, is you go into a strategic planning exercise, but those people who are administering it or leading it often have got the end in mind before you start. You haven't got the freedom to talk about where things are at, and it is really short-sighted. But we took a novel approach. We went outside of the health industry. So we brought into our workshops, and we ran 2 or 3 of them, the grocery industry, the airline industry, the other travel industry, the local airport. We started to look at the distribution model of warehouses, of the grocery industry, and how they actually delivered services right place, right time. Our local airport, there was 13 different players that get you into the airport and onto a plane and mostly get you to the destination with your luggage, but there wasn't a service level alliance or agreement amongst any of them. And so it became really fascinating. We became obsessed around structures and service level alliance and memorandums of understanding, that actually most of us just got to the airport, hopped on the plane, got to Wellington and got home again, and didn't think about those relationships. So we went to the District Health Board and we said, we don't want you to focus on the health services plan. What we want you to focus on is these 3 strategic goals, and that's all we want you to agree to, which is people taking greater responsibility for their own health, and the development of services that support people in whānau. So whānau is loosely the Māori terminology for family, but Māori talk about family in a wider context than you and I would think about a nuclear family process. So lots of people end up being whānau when you talk to Māori, which is quite fascinating. But the essence of that was, we've got a responsibility if we're going to try and develop our health system and manage it for the future, to actually give people the tools to manage their own health. The second was people stay well in their homes and their own communities, and that for most people their continuity of care will be delivered by a general practice team. We need to redefine what we mean by that now, but that gave general practice a real place in the system, and gave them a buy-in and a connection. And the third was people receive timely and appropriate complex care, and so it was really about freeing up those hospital resources. They're important places, but they need to be accessible and responsive, and we also need to be able to provide those services closer to people's homes if we can. If you want to be incrementally better, be competitive, but actually want to be exponentially better, be collaborative. And so it was a game changer in my experience of thinking differently about doing things. Now, it's really difficult, and it still remains difficult for me today in the roles that I have, because naturally it's human nature, competitive. I love my sport, so I've got a bit of an extra edge to myself, but you've really got to keep reminding yourself that a health system, that our communities require us to be collaborative. So we designed this, the Canterbury Clinical Network. It's not an organisation, it's not an entity. It's a group of people who have come together. So what we decided to do when we wrote our response to the Minister's request was, we said, actually we need to collaborate to do this, and we need to do this together across Canterbury. One system, one budget, we know the mantra, and we turned this thing called the Canterbury Clinical Network, which was a place for the players in Canterbury to come together. No one organisation, just the players come together and finding a place where they can co-design the system, with the agreement of the Commissioner, that if the design and the pathway was right, they would find the money to spend. How can we stitch this thing together? So we went to the construction industry, and they introduced us to alliancing, which was primarily around complex projects, building bridges, high-risk projects, but brought together really hardy groups of people, and said, and it was a best for project focus to it. So we took on a best for patient, best for system approach. And so the Canterbury Clinical Network is a program office of 5 people, that's all it is. But the players across the Canterbury health system sit at its leadership table, and they're all clinicians except for the Commissioner, the head Commissioner, the head planner and funder sits at that table, and one other person who's an independent chair. And so we chose a High Court judge, and the work that goes on underneath the Canterbury Clinical Network is a range of population streams, aged care, rurality, and other things. And then it has a range of what we call service level alliances. So it looks at pathways of activity. So it looks at the acute demand program that I'll touch on shortly, and other things, and designs and co-designs the system for better patient outcomes. We're finding it very successful, and that was really difficult for our organisation. We had to cede our sovereignty into this network, because we had been a system player, we'd been a system leader, we'd been a darling of the system, and all of a sudden to start saying everybody else is an equal at this table was something hard to swallow. But I believe the greater good's been achieved.